So, hello. Today for the e-chat, we will have with us Professor Massimo Antonelli from Rome, who is a world expert in critical care medicine, and in particular on non-invasive respiratory support, which will be our topic today. Hello, Massimo.
Hi, Jean-Louis. Thank you for inviting me.
You are welcome. Am I right that you are the first one to have described the use of helmet maybe about 20 years ago?
You are right. Indeed, I did that 20 years ago, and I was the first using this device with pressure support.
So this system has become quite widely used in Italy, and then, of course, in other European countries, in other countries in the world. But it seems that the US have discovered it relatively recently. Am I correct?
This is absolutely correct. Probably this was due to the fact that the FDA was reluctant in accepting a device not offering for them enough guarantee of safety.
And so you just published in the JAMA a couple of days ago the results of this trial, which has a terrible name. It's called HENIVOT, a trial where you compared helmet with high flow nasal oxygen therapy in patients with COVID. And the conclusion of the paper is quite negative. So is it a negative trial, Massimo?
You know, it's negative looking at the primary outcome. The primary outcome were the ventilator 3 days from any form of ventilation. And in this term, the study was negative. On the other hand, the secondary outcome, which was the rate of intubation, was indeed strongly in favor of the use of the helmet. So I would say that is in part negative study.
Would you say that you choose a wrong endpoint, primary endpoint?
This is a good question. Probably we could have chosen the other one, the intubation as a primary outcome, but this would have implied a much larger population.
Exactly.
And so we wanted to have a preliminary data on basing on them for future larger trials.
Yeah, absolutely. Now, as you say, it was rather in favor of the use of helmet. But my question is, do we need a randomized controlled trial on this particular type of question? Or could I just try it and use it and see if it works well, if the patients are happy, etc., to make my own experience? Should we have a one strategy for every single patient?
You know, both of us are not always in favor of the randomized clinical trials. They do have drawbacks and advantages. However, in this specific case, the physiological issues were already investigated during the previous years. One of the major problems, I guess, is when you have a study like this, having a bias on part of the investigator. That is why, being impossible blinding such a study, because it's visible what you are doing, we choose to use a randomized trial in order to get a more reliable conclusion.
That makes sense indeed. So what would you say are the main advantages of the helmet?
You see, fundamentally the tolerance, because as soon as the patient is dyspneic and tachypneic and hypoxemic, the possibility of applying non-invasively through a transparent hook, a relatively high pressure capable to recruit the lung, can be an advantage. And in terms of tolerability, don't forget that the patient can also drink through seal connector, can have a vision of what is going around, and just helping them accepting the device. This can be a profitable way to treat them also for more than 48 hours continuously.
Now, you compared it to high flow nasal oxygen, but what about CPAP by mask?
You know, CPAP by mask is a different issue, but the CPAP may be also delivered through the helmet. But this is another story. Our plan for the future will be to rearrange a new trial with 3 different arms, one of those including the helmet or the face mask CPAP. Nobody knows at the moment if it is better or worse having the CPAP instead of the pressure support.
Because here we are focusing on COVID-19 patients, maybe the risks of aerosols, reaching the healthcare personnel may be an issue.
It can be an issue when you use a mask. With the helmet, it's much less, also because you connect to the HEPA filter and the mechanical ventilator, and consequently, the nebulization into the environment is very, very limited, and it's even safer for the personnel.
Yeah, I like very much the drawing which is in the JAMA, accompanying the editorial, I believe. But my question is it easy to set up? I know the answer because we use it, but for those who have not used it, is it easily applied? Does it require some experience?
This is a very good question, because apparently it seems to be very easy to put the helmet on and just manipulate the ventilator in 2 or 3 different items. But indeed, you need an experience. At the very beginning, you need to start by step by step, and there are a number of inconveniences that implies the presence of the nurses at the bedside and the doctor, increasing at the beginning a workload that should be taken into consideration. For just setting up the machine, the pressure support is not very difficult, starting from at least 10 centimeter of water of PEEP and 10 of pressure support, in order to consider that part of the pressure that is delivered is spent to distend the helmet, and only part of that reaches the patient. The disadvantage is that at present, you cannot know the amount of tidal volume you are delivering to the patient. Yeah. You have to, based on a clinical judgment and hemogas analysis, the effectiveness and the safety of your procedure.
Do you think in the future it will be possible to assess the tidal volume?
We are working on that, probably yes. It's a bit sophisticated to do that. But we are also, because you need to instrument the patient in an invasive way. We are working on that. We have already published some data concerning that, where it has been shown that placing a nasogastric tube for measuring the esophageal pressure as a surrogate, the transmural pressure, or the negative of the pleural pressure, we could demonstrate that there was a clear-cut reduction in hypoxemic patient of the work of breathing. Yeah. Also reducing the swing, which is one of the preoccupation of many investigators, saying that keeping the spontaneous breathing may induce an harm to the lung.
Sure. Is CO2 rebreathing sometimes a problem?
No, not at all, for a very simple reason, that physiologically the CO2 they're breathing is function of 2 variables, the CO2 production and the flow that passes through an environment, whatever the environment may be. And this is the same in the helmet. Provided the fact that you have a sufficient flow through the machine, the rebreathing is really negligible. Also because these patients do have a low level of production of CO2.
Yeah, sure. Occasionally we find a patient who is a bit claustrophobic with it. Is it the experience?
I didn't receive...
Some patients may be somewhat claustrophobic when you put the helmet.
Yeah, sure. It happens at times. In this case, in principle, this should be contraindicated like any other form of non-invasive ventilation. Patients who are claustrophobic toward the helmet are also claustrophobic for the mask. So in general, at times when we do not have any other alternative, because the patient cannot be intubated for any given reason, we may use a mild sedation, in general using dexamethasone.
Yeah, that's also my question. Are we speaking only about the system, the technique used, or are we looking at a package because sedation may be a bit influenced by the technique you choose, or perhaps the use of prone positioning. Maybe it's not as easy with the helmet as with a single nasal flow.
Well, as any other form of non-invasive ventilation, implicitly, it has also the need of having a workload for the nurses and doctors, which is at the beginning higher than for an intubated patient. But however, as you said, it's a package, and at times, if you may need a sedation, you may use it. Or you can also use the prone positioning. You know that with the CPAP mode, the Monza group in San Matteo, in San Gerardo in Monza, they have used and published in a Lancet Respiratory Medicine a group of patients with COVID-19 and placed prone with the helmet in CPAP.
Yeah, exactly right. Yeah, okay. And what about the costs? Just one word.
The cost is roughly 200 euros.
Yeah. Okay, so let me finish up by asking you then, practically speaking, you have a patient coming in with COVID-19. He has an SpO2 of 70% on high FiO2. The respiratory rate is fast. The patient is dyspneic. What is your first choice? Do you immediately start with helmets, or
no?
What do you do?
If the patient is breathing room air, what we do is we try to start with the high flow oxygen therapy. If it works and we can get some improvement, okay, fine. Otherwise, at least in our experience, we have another step. We change the level, and in this case, we use the helmet, placing the helmet on and using the pressure support. If it doesn't work, of course, the only possibility we can get is just to intubate the patient, put him prone, and so and so and so.
Well, but then how could you randomize patients in your study? Because you say you start with high frequency, with high flow.
Yeah. Sorry. I thought that you were asking a practical question.
No. That's the point. That's the point.
Yeah. In everyday clinical life, what we have done in the paper is something different, because the first thing that we did was just to deliver oxygen through a face mask, a Venturi mask, for instance. And after that, we randomized the patient if the criteria were fulfilled.
But it's interesting to hear your practical approach, which is the same as the one we would take.
Well,
I'm afraid our time is already up. So this was very interesting, and we recognize the expert in you. Congratulations on your excellent trial, and many thanks for this very useful information.
Thank you very much.
Grazie. Ciao.
Ciao.
Bye.